Thank you very much for the very kind introductions. Very good morning. I really appreciate your invitation to be here. I have been here for the last 2 days, been to the countryside, and have toured around Colombo. I'm really impressed with how beautiful your country is, and the warmth of the people is really, really fantastic. So on behalf of AUA, I'm here to speak about this topic, the role of local radical treatment in metastatic prostate cancer. As early as 2 or 3 years ago, and if you put this title together, people thought that, really, are you serious? Are you talking about radical local treatment in the setting of metastatic disease? We do that all the time for kidney, but are you really serious about talking about this topic in metastatic prostate? The reason I'm here and giving this talk is to show you that some of the advances has happened over the last couple of days, and this is a topic that we have to revisit and to be aware of, because in the next couple of years, things will likely change in this space. So this is my disclosure. I've done a few talks for the pharma company, and I'm an inventor of the machine that's being used as the standard of care, at least in my part of the country, for early prostate cancer detection. So managing newly diagnosed de novo metastatic prostate cancer. So this is the outline of my talk. I'm going to talk a little bit about local morbidity of patients with de novo metastatic prostate cancer. And then I'm going to talk about the role of local radical treatment, being surgery or radiotherapy in the setting of metastatic prostate cancer disease. So really, we all know that local radical treatment in the setting of metastatic disease is non-curable. So the goals of using local radical treatment in the metastatic setting in general are limited to two. So first is to allow patients to live longer, and that's why it's specifically the cancer-specific survival. This should be done as part of a multi-mortality treatment regime. It shouldn't be just local treatment alone. So in metastatic prostate cancer, it will be surgery or radiations, plus systemic therapy, because it's a systemic disease, and systemic therapy has to be the mainstay of treatment. And the validity of this kind of approach should be proven by clinical trial. The second commonest, or more easier to understand goal for this kind of treatment would be for palliations, and to allow patients to live better in the setting of palliating their symptoms. And don't forget that patients with metastatic prostate cancer still come with a lot of local symptoms, and there's obstructive urinary symptoms or complications. I think it's always interesting in a clinical talk to start with a clinical case to set the scene for the subsequent discussions. So I have here a clinical scenario. These are patients that I saw just before COVID. A banker, relatively young, 68 years old, quite fit, jog every day, only had hypertension and hyperlipidemia. So December 2020, almost 2 years ago, he had worsening LTS, poor flow, incomplete emptying, and that's why he turned up at the urology clinic, and the DIE showed a very suspicious prostate. The PSA at that time was 70. So he has a MRI as part of his assessment, and they show quite bulky lesions, Pilus 5, with local infiltrative features. So he went on to have a robotic transperineal MR targeted biopsy. This is what we do now. We don't do transrectal biopsy anymore. They show quite high-grade Gleason 4+3, 6 out of 6 cores. So further staging, a little bit controversial. We don't commonly use PSMA in the past, but we've been using a lot. But now we've come back, we've gone a full circle, we come back and we try not to do too much PSMA PET-CT now, because he's a very well-informed patient. He has looked up the internet, and this is what he wanted. He wanted a PSMA PET CT scan, and that show a limited oligometastatic disease with 3 metastatic sites. So in summary, this is a relatively young, highly functional individual who have obstructive symptoms with a T3M1B oligometastatic prostate cancer. How we go about treating these patients? I mean, as I say, these are systemic disease, and systemic disease requires systemic treatment. The standard of care for him now would be hormonal treatment, ADT, with some form of intensifications, with one of the 3 or 4 novel hormonal treatment available to us now. So he has ADT with LHRH agonist plus one novel hormonal treatment in the form of enzalutamide. Is that all he needs? How about local treatment for him? Okay, apart from the standard of care systemic treatment, I think whether he requires local treatment or not would depends on how morbid is the disease. So for palliative intent, when we offer local treatment for patients with metastatic prostate cancer, we need to understand the natural history of the disease. For patients that present with de novo metastatic prostate cancer, we did a study in my institutions. This was published just 2 years ago. They look at the local and systemic morbidities of patients that present with de novo metastatic prostate cancer, almost 700 patients over 20 years. And we look at how these patients present and what kind of local morbidity they have. Okay, so actually we're quite surprised. Almost 90% of these patients present with symptoms, and about 81% of them present with bone pain, 27% hematuria, and about 42% of them present with urinary obstructions, very similar to the case I just presented. About a third of them, there's 34%, require palliative treatment for the obstructive symptoms. That is mostly in the form of a channel TURP. About 12% of this require immediate urological interventions, and 10% require repeated urological interventions in the course of their disease. So what are the commonest local interventions? As I say, TURP to relieve the local obstructions, PCNs to relieve the upper tract obstructions, urethral stenting, and TURBNI. It's quite expected. And we did a multivariate analysis to predict who are the patients that will go into trouble. So the patient with a very high PSA of 100 and the PSA with a large prostate of more than 50, and these are the patients that would most likely run into the problem of local morbidity, most likely with some form of obstructions. And patients who are very poor risk in terms of their functional status, and we have high metastatic volume, and these are the patients that are more likely to run into the risk of fractures and skeletal event. So in conclusions, based on our study that was published, more than 90% of these patients, the patients that present with de novo metastatic prostate cancer, at the moment we are still seeing about 15% of these patients are all patients that present with metastatic prostate cancer, and in other parts of the world it could be up to even 50%. So about a third of these patients will require local palliative urological procedure, most likely in the form of TURP, and about 10% of these will require repeated palliative interventions. Prostate volume of more than 50, PSA more than 100, and these are the patients at risk of local morbidity, and look out for these patients. The early recognitions of this risk factor would actually predict for the requirement or the need for local interventions, and that allow you to treat these patients expectantly. So for these patients who are very symptomatic, prostate is quite large, more than 60, and most likely will require some form of local treatment, okay, and be it TURP or some form of other local treatment. Then you ask, how about doing a radical prostatectomy on him? Because he's going to run the problem with local morbidity, instead of doing a TURP, why don't we do a local prostatectomy on him? It can be done very safely. Because if you do a TURP, our data show that 10% of them will come back. And you need to repeatedly doing a TURP on them. So there's a very provoking thought. Doing a radical prostatectomy in this group of patients, is it indicated? So this is the questions I put up, and it's rather provoking. So now we are talking about, is that really a role for local surgery? Okay, local prostatectomy instead of doing TURP on these patients? Is it really a role on that? So the other role of doing local treatment, as I mentioned, is to try to improve on their overall or cancer-specific survival. Not only to improve on their local morbidity, and also to give them overall or cancer-specific survival. In fact, this is a topic that is fast emerging and being hotly debated. The role of local radical treatment, be it surgery in the form of cytoreductive surgery, or using local radical radiation therapy. So you're going to hear a bit more on this in the next couple of years, but what's the status now? So you can see here, this is a guideline, NCCN guidelines, for patients that present with castration-naive prostate cancer, that's hormone-sensitive metastatic prostate cancer. Okay, so you have hormonal treatment. You get hormonal treatment, systemic hormonal treatment, with some form of intensifications with one of these novel hormonal therapy is the mainstay of treatment. But for the first time, local radical treatment in the form of radiation therapy has made it to the guidelines. So for patients with oligometastatic prostate cancer, I mean, the convention in the past is leave the prostate alone. But now, it has made it to the guideline that is recommended that you refer patients for local radical radiations to the prostate. It has made it to the guideline. Okay, whether surgery would come soon after radiation therapy to be recommended for these type of patients. Is it possible? I think time will tell. Why? Why do we offer radical radiation therapy to the prostate in the setting of a disease that has spread beyond the primary organ? So this is as a result of quite a big trial, the STAMPEDE trial, in the H-arm STAMPEDE trial. As you know, this is a randomized control trial that has many, many arms. They try to answer all questions about prostate cancer under the sun. So quite a big trial. Is a control arm, about 1,000 patients with standard of care. There's hormonal treatment with or without chemo versus standard of care plus radiotherapy. So radiotherapy was given in this setting, 55 gray, 20 daily fractions, or 36 gray over 6 weekly fractions. So the metastatic volume is defined using the charted criteria. I mean, 4 or more bone mets with one extra axial lesions is considered as high volume. So we look at overall survival, failure-free survival, metastatic-free survival, and symptomatic local events. This is what they found. So in terms of overall survival, there's no difference between patients who have standard of care and patients who have standard of care plus radiotherapy. But if you look at a subgroup of patients who are divided into metastatic volume, the group of patients with low metastatic volume, really, you can look at it, the overall survival curve has diverged. So there's overall survival benefit for patients with low metastatic volume and failure-free survival benefit as well for patients with low metastatic volume that receive radiotherapy in addition to standard of care. In terms of grade 3 or grade 4 radiotherapy toxicity. Actually, you look at it, there's hardly any difference, and it's quite well tolerated. But if you look at symptomatic local events and local morbidity for patients who have standard of care and for patients who have radiotherapy, radiotherapy doesn't do a thing, didn't do a thing for prevention of local disease progressions and local morbidity. You may give overall or failure-free survival, but the patients may not benefit from palliations of their local morbidity symptoms. So during treatment and after treatment, in fact, after treatment, you can see they fare worse in terms of local morbidity. So in summary, this is a very large trial. They give almost a level 1 evidence, and as a result of this trial, the recommendations of local reticle radiotherapy for the primary organ of prostate has been recommended. However, there are many shortfalls, and in this trial, the standard of care is a little bit outdated now. It's no longer a standard of care today because with all the hormonal treatment that novel hormonal intensifications that we are doing. And the radiotherapy doses are actually quite heterogeneous, and they are not standard, and they are not really radical doses. Okay, 55 gray is not 74 that we are giving now, and there's lack of quality of life data. I mean, you can criticize the study, but the data is out there. So for oligometastatic prostate cancer patients, the standard of care now is systemic treatment plus local radiotherapy to the prostate. Okay? So how about surgery? Would one-day surgery be up there? If you talk about cytoreductive surgery or cytoreductive treatment for primary organ in the metastatic setting, there's no better cytoreductive treatment than surgery. Surgery, by removing the primary organ, this is the best cytoreductions that you can have. And surgery has an added advantage that you will elevate the local progressions and local morbidity. Are we going to see one day that surgery would be recommended in this setting? And the jury is still out. There are about 8 to 10 RCT currently being conducted looking at these questions. And most of these are head-to-head comparison between RT versus surgery versus standard of care. So hopefully in the next 2 to 3 years, we might know a little bit more as a result of this ongoing RCT. Okay, I just want to direct your attentions to one of these trials. This is not the RCT. This is the earlier ROMP trial. This is a prospective registry study of patients, small sample size, 48 for the cytoreductive prostatectomy group, 26 for the reticle radiotherapy group, and 35 for no local treatment group. See what the results. Bear in mind that these are not RCT data. And you can see here, patients who had radiotherapy and surgery almost in a similar curve compared to patients without local treatment in terms of overall survival and cancer-specific survival. So we know that local treatment, okay, do something in terms of giving them, prolonging their life, increase the overall survival and cancer-specific survival. But this you have to take with a pinch of salt. This is not RCT. This is a prospective case control study. But it does show that if radiotherapy has some effect in the RCT trial, in STAMBIT trial, and you can infer from here, surgery is probably doing the same. Okay, how about local event-free survival, local morbidity? Okay, again, these show the superiority of surgery. Okay, for okay, you see, for the let me see, for the cytoreductive prostatectomy group, The local morbidity is 14%. For the radiotherapy group, 30%. No local treatment group, 37%. So about a third of these patients will suffer quite bad local morbidity, and surgery cut it by more than half. Okay, so local treatment by radical prostatectomy, we don't know whether they are going to prolong their survival, but we know that it's the most superior treatment in controlling local progressions and morbidity. And if you look at, these are the data that we pull for patients which has hormone-sensitive prostate cancer requiring surgery for local progressions, standard of care 23%, standard of care plus radiotherapy 27%, control almost 30%, patient with cytoreductive radical prostatectomy 0%. How about CRPC patients? Again, you look at no treatment, 40-something%, external beam radiotherapy, 30-something%, radical surgery, single digit. So you can see a very dramatic improvement and benefit for local progressions for patients with metastatic prostate cancer if they go through surgery. So there's no level 1 RCT data, but we do know that based on all the literature, this is something that I put up. The argument for radiotherapy in this setting, in the oligometastatic setting, is we have level 1 evidence based on the STAMPEDE trial. It's non-invasive. The toxicity is very much acceptable. There's potential indirect benefit as well for radiotherapy of the Escobar effect. Okay? But the argument against radiotherapy in this setting is the level 1 data is probably not really very high quality level 1 data, because there's still a lot of questions on the dose, on the standard of care arm. And the radiation regime and the dosage are sub-radical, and there's local, they didn't do a thing on local morbidity. The argument for surgery, even though we have no level 1 data, is that the argument against would be there's no level 1 data, it's invasive, potentially have complications, there's no unknown off-target effect like radiotherapy. But the arguments for cytoreductive radical prostatectomy will be, there are quite a few trials being conducted now. Some of them would be available in the next 2 or 3 years. It's a well-established MIS technique, and morbidity is very low now in the hands of robotic surgeons, or even in the open setting, and excellent local control. This is my last slide. So for these patients, should we have TURP or should we have radical prostatectomy? I think the jury is still out. At the moment, what we can tell them is we can consider, if patients consider to have it done under clinical trial. So the best patients for cytoreductive radical prostatectomy in the future, if it's going to be recommended, would be patient with low volume oligometastatic disease, patient with excellent PSA response to systemic therapy, they're completely resectable organ-confined prostate cancer. There's a lot of local infiltrations. There's patients with obstructive symptoms that you can also alleviate, and patients are willing to enter a clinical trial to evaluate the role of it. So this is my last slide. So in conclusions, de novo metastatic prostate cancer is actually quite a morbid disease. And 90% of them present with symptoms. A third of them will require surgery for local progressions. The role of local treatment to the primary organ and tumor, at the moment, we have data and recommendations for radiotherapy based on the STAMPEDE data. But be wary of the at-risk group of patients that are called patients with very big prostate, very high PSA. And these are the patients that run into problems with local morbidity, obstructions, and they can be quite miserable. And surgery didn't do a thing for them in this regard, and surgery could still be required. The role of cytoreductive prostatectomy, there are 9 RCT ongoing. We have limited case control data that show that it probably offers the same benefit as radiation, in addition to the benefit of getting rid of the local morbidity. And it should be conducted in a clinical trial setting. So with that, thank you very much for your invitation again, and really, I really enjoy my stay in Sri Lanka.